The OR is too bright, too cold. The ventilator hisses. The monitors spit out twin heartbeats that never quite sync, a frantic duet fading into one thin line. My gloves smell of chlorhexidine, and the weight of my headlamp presses a groove into my forehead as I stare at the ultrasound. One heart, enlarged, failing, trying to feed two bodies fused at the chest. Epinephrine ready, anesthesia says. The scrub nurse lays the vascular clamps like cutlery. If I clamp the shared outflow tract, the one vessel carrying oxygenated blood to both brains, the weaker twins, pressure will collapse first. We can put one on bypass. Maybe. We cannot invent a second heart. Behind the glass, their parents' hands are knotted together, mouths forming silent prayers I can't answer. To save one, my incision will doom the other. And it didn't start in this operating room. It started when the ambulance doors opened 8 hours ago. The call came during the half hour that isn't really a bakery. Coffee has already turned bitter, and the pager sits on the table like a live thing. Pez Ed needs you, the operator said. And behind her voice, I could already hear it. The distant churn of a transport team rolling a stretcher to fast. The soft alarm of a pulse ox losing its signal. In the trauma bay, the air tasted like plastic and antiseptic. Two bodies. One chest skin stretched over a shared sternum. Tiny ribs rising together under a single set of adhesive leads. The monitor tried to make sense of it anyway, throwing numbers at us. Heart rate 170,170. Oxygen saturation drifting between 8,888% and 9,292%. Blood pressure that dipped every time the weaker twin's chin fell forward with sleep. The respiratory therapist adjusted the high-flow nasal cannula. The sound was oceanic, a constant rush that couldn't hide the fact that their breaths were getting shorter. 6 months old, the paramedic said, voice flat from repetition. They were stable until this morning. Increased work of breathing, gray around the mouth. Local hospital did a bedside. Echo said the shared heart looked big. He hesitated on the last word, like he didn't want to insult something sacred. He handed me the run sheet with trembling fingers. Dried gel from the ultrasound still clung under his nails. I stepped closer and watched the stronger twin track the room with bright, irritated eyes, while the smaller one blinked slower, as if each eyelid weighed ounces. The stronger twin's fist kept opening and closing against the other's shoulder an unconscious rhythm, a reminder that even fused bodies still have separate tempers. When I touched the smaller one's foot, it was cooler than it should have been. And the capillary refill, how fast the pink comes back after you, press lagged by a beat too long. Perfusion is a word we say calmly, but it's really a countdown. Their parents stood just inside the doorway, not entering, as if crossing the threshold might make it official. The mother's wrists were marked with the faint red lines of a hospital bracelet she'd worn before labor and delivery. NICU, a life of coming back. The father's hands hovered near his pockets but never went in. He kept rubbing his thumb along a wedding ring like he could sand it down to nothing. I'm Dr. Halpern, I said, and forced my voice to stay steady. I take care of hearts. I'm going to examine them, and then we'll talk. The mother nodded to fast. The father didn't nod at all. He just stared at the twins' shared chest, as if waiting for it to apologize. We moved like a practiced machine. Blood gas, first an arterial sample that came back with a rising lactate, the kind of number that tells you tissues are starving even before skin changes color. BNP, one of the lab markers that spikes when the heart is stretched and struggling, was elevated enough that the resident's eyebrows jumped. Chest X-ray showed a silhouette that looked too wide to round, the heart shadow swallowing the center of the image. When the ED attending mentioned heart failure out loud, it landed in the room like dropped metal. The echocardiogram confirmed what the rural team had only guessed. One heart, structurally complex, closer to a single ventricle physiology than two clean halves. It was working beyond its design, pushing blood through a shared circulation that didn't care about fairness. One twin, the stronger, was stealing flow during stress, not out of malice but out of physics. The smaller twin's oxygen delivery fell first. The heart compensated by racing. The racing worsened the failure. The cycle was elegant and cruel. I pulled the parents into the consult room because some truths need walls around them. The room smelled faintly of bleach and old paper, and the only artwork was a landscape that could have been anywhere mountains you could pretend to escape to. A social worker sat with them, quietly placing a box of tissues within reach, but not too close. On the counter, a laminated sheet explained patient rights and financial assistance programs in 6 languages. It felt obscene beside what I was about to say. "Can you fix the heart?" the mother asked. She didn't cry. Her eyes were dry and shining, like she'd run out of water on the way here. "There isn't a repair that makes one heart become 2, I said. I hated how simple that sounded. "We can support it medications like milrinone to help it squeeze, diuretics to pull fluid off the lungs, oxygen, maybe a ventilator. But support isn't the same as a solution." The father finally spoke. "We have insurance," he said, then swallowed. It wasn't a demand. It was an offering, proof that he'd done something right. In the United States, I've watched families learn the language of survival: deductible, network, authorization. None of it belongs in a room with 2 babies sharing a heartbeat, but it always shows up anyway. "In an emergency, we treat first," I said, meaning EMTALA, meaning decency, meaning I didn't want money to be the monster in their story. "The hospital will work with you. Right now, what matters is time." The mother's fingers tightened around the tissue without using it. "This is my fault," she whispered. And the words weren't addressed to me, they were aimed inward. At every prenatal appointment, every vitamin. Every night she'd replayed the ultrasound where the tech fell silent. I didn't contradict her too quickly. I've learned that if you slap reassurance onto guilt, it slides off. A lot of conjoined twins happen without a reason anyone can control, I said. "But I hear you. And I'm sorry you've been carrying that alone." The surgical team arrived in Picu's pediatric surgery. Anesthesia, perfusion. A chaplain drifted in after someone must have paged them. They didn't introduce themselves like a savior, just sat nearby, hands folded, occupying silence, the way only someone trained in grief can. We laid out the options on a whiteboard because families deserve to see the shape of the trap, continue medical management, and watch the heart fail. Pursue separation knowing the anatomy made it impossible to give both twins adequate circulation afterward. Consider transplant, a fantasy in the timeframe their labs were describing. Every path had a loss baked in. When I returned to the bedside, the smaller twins' breathing had changed shorter pulls. A faint grunt at the end of each exhale, the body's primitive attempt to keep air in collapsing lungs. The stronger twin turned their head, forehead pressing lightly against the other's temple. And for a second it looked like comfort. Then the monitor beeped louder, the saturation dipped, and the respiratory therapist's voice sharpened. "We're losing them." I stared at the shared chest rising unevenly and felt the room narrow to one question we weren't ready to answer out loud yet. If we waited for certainty, would there be anyone left to save? The first thing I noticed was the sound changing. The monitor didn't just beep, it started pleading, the pitch tightening as the oxygen saturation slid. In the PICU bay, everything smelled like warmed plastic from the high-flow cannula and the sharp sting of alcohol wipes. And I could taste the stale coffee I never finished as I pulled on a fresh pair of gloves. I'm the one who stays at the bedside when the room fills with titles. Surgeon, fellow, attending, respiratory, everyone arrives with a plan in their eyes. But my job is the same. Watch the skin, the lips, the tiny pauses between breaths that tell you a number is about to become a disaster. The smaller twin's mouth had gone from pink to the color of damp paper, and the stronger twin's legs kicked once hard like their body sensed the danger before anyone said it. Sats 79%, 79%. I called out. Heart rate 190,190. The arterial line waveform looked like a tired hand trying to wave. When I pressed my fingers to the smaller twin's foot again, it was colder, and the pulse felt like it was slipping away from me on purpose. Respiratory leaned in. "They're tiring out," she said. And there was no drama in it, just that calm voice people use right before they do something violent to save a life. She opened the intubation kit, and the crinkle of sterile packaging sounded too loud in the hush. The ventilator in the corner waited like a machine with its mouth open. The parents were at the glass again, as if the transparent barrier could protect them from the moment that was coming. The mother's palm was flat against the window. The father's forehead hovered a centimeter away, not touching, not letting himself be comforted by anything. I saw their lips move. Silent bargaining, the kind that has no audience but God. "Let's intubate," the attending said. IOT now. He explained it fast. Endotracheal tube. Control the airway. Reduce. The work of breathing while anesthesia drew up meds with hands that never shook. The smaller twins' chest muscles were tugging with each breath, ribs showing like a zipper. This wasn't a choice anymore. It was a closing door. We positioned them as best we could, but conjoined anatomy turned simple angles into compromises. The stronger twin put the mask, flailing, and I held their tiny forearm gently but firmly, feeling the heat of their skin through my glove. "I'm sorry," I murmured, not because they understood the words, but because my body needed to say something human while we did something clinical. Ketamine in anesthesia called. Rocuronium. The stronger twins' movements softened, then stopped. The smaller twins' eyelids fluttered once like a moth against a light, then stilled as the paralysis took hold. For a breathless second, both bodies were quiet, and the room became a chorus of equipment: suction gurgle, monitor alarms, the soft hiss of oxygen. The laryngoscope went in. I watched the physician's shoulders tighten, the subtle posture of someone trying to see around. Anatomy that refuses to cooperate. "I've got cords," he said, and the tube slid through with a smoothness that made my stomach drop anyway. We confirmed with entitled Codois little waveform that means the tube is where it should be. The ventilator took over with a rhythmic push-pull that felt both reassuring and obscene. It bought us minutes, not safety. The saturation climbed to 86%, then stalled, then dipped again as the heart tried to keep up with a body that had become two demands at once. The shared heart's rate stayed high. Tachycardia, the last tool a failing pump uses. Milrinone started dripping through the fore, a medication that helps the heart squeeze and relax more effectively. But it also drops blood pressure, and the smaller twin didn't have pressure to spare. "BP's falling," I said. The arterial line trace flattened, each pulse a smaller hill. Mean is 3,232 in the corner. The surgeon stared at the echo images on the screen. One heart, strained, valves leaking under stress, his jaw clenched like he was biting back a sentence. "Start epinephrine," the attending ordered. The syringe pump clicked as it began its tiny, relentless delivery. Epinephrine is adrenaline with a medical license. It tightens vessels, boosts squeeze, forces the body to keep going. In a baby, you can almost watch it happen. The skin blushes a shade warmer. The pulse returns like a reluctant guest. Then the smaller twins' rhythm changed. It wasn't dramatic at first, just a weirdness in the tracing, a widening of the complexes, a pause that didn't belong. The monitor announced it in its impersonal way, alarm tone, flashing numbers. The kind of noise that makes everyone's spine straighten at once. The heart rate dropped from 190,190 to 120,120, then to 7,070, like a candle guttering. "Bradycardia," I said. "They're crashing." The room snapped into a different choreography. Someone lowered the bed. Another person climbed onto a stool because the shared chest made standard CPR landmarks a guess. The attending's voice sharpened. If we lose pulses, compressions. Now, I felt for a pulse and found only the echo of my own heartbeat in my fingertips. "No pulse?" I said, and it came out flatter than I felt. The surgeon didn't swear. He just nodded once, like he'd been expecting the universe to be consistent in its cruelty. Compressions started 2 fingers, then the heel of a hand, adjusted again because one sternum didn't map to one patient. The chest moved under pressure, skin blanching and pinking back, while the ventilator delivered breaths that sounded to clean for a moment this messy. Epi 0, 10.01 milligrams per kilogram. Someone called. And a nurse pushed it with the grim precision of a person who has done this before and hates that fact. At the glass, the mother's knees buckled. The social worker caught her before she fell, one arm around her shoulders, and the father's mouth opened in a soundless shout. He banged the door once, one hard knock, then froze, hand hovering in the air like he didn't recognize his own impulse. Security didn't move. No one tried to quiet him. Some grief is a medical emergency too. We got a rhythm back then, fast, barely adequate. The monitor settled into a tachycardic line that looked more like panic than recovery. The smaller, twins' oxygen saturation stayed low despite maximal settings. And the blood gas came back worse, rising CO to CO2, worsening acidosis, lactate climbing like a tide. The numbers weren't just data. They were the body's way of telling us it was losing the argument. The surgeon leaned toward the attending, voice low enough that it was almost private, but I heard it anyway. "We can't keep them like this," he said. "The heart won't hold. If we don't separate, we're going to lose both." No one answered immediately. In that pause, I watched the stronger twins' fingers curl still, even sedated until they rested against the smaller twin's shoulder. A touch that could have been accidental, a touch that felt like a goodbye. The conference room was built for decisions that fit on paper. A rectangle of artificial light, a whiteboard that still carried a faded reminder about hand hygiene, and a speakerphone in the middle of the table like a small black witness. I could still hear the ventilator from the hallway, its steady push of air that pretended this was stable. I washed my hands until the skin at my knuckles stung, then sat down and tried to arrange my face into something families could survive. The Picu nurse gave me a look that said, without words, that the smaller twins' pressures were only holding because we were forcing them to. The echo images were pulled up on a laptop, the shared heart pulsing on screen like a struggling animal caught in a net. The ethics consultant arrived with a thin folder and tired eyes. The kind you get from walking into other people's worst days for a living. A chaplain sat quietly in the corner, not praying out loud, just present and anchor for anyone who needed to fall apart. Pediatric surgery slid into a chair beside me, shoulders tight, as if his muscles were still braced over an open chest. When the parents entered, the mother moved like she was afraid her body might make noise. The father's jaw worked once, as if he was chewing on a sentence he couldn't swallow. They sat together but didn't touch, their hands on their own knees like separate islands. I didn't start with the cruel sentence. I started with what we had done. "We intubated them to take over breathing," I said, keeping my voice low. "We're using medications, epinephrine and milrinone to help the heart pump. But the heart is failing faster than our support can keep up." The father's eyes flicked to the ultrasound clip, then away. "So, you're saying they're dying," he said, and it wasn't a question. "I'm saying we're running out of time," I answered. "The difference is tiny, but families feel it. Time means there's still a door. Dying means it already shut." The mother leaned forward, elbows on the table, and her hands began to twist the tissue into a rope. "You said earlier there wasn't a repair," she whispered, "but there's a surgery. The separation. You wouldn't be talking about it if it wasn't possible. It's possible to separate their bodies." The surgeon beside me said, voice measured, "It's not possible to give them both enough blood flow afterward." He looked down when he said it, like he hated his own honesty. I pulled up a still image of the heart anatomy and pointed, because sometimes a picture holds the scream so the room doesn't have to. This is the shared outflow, I said. Right now, one heart sends blood to both of them. The smaller twin is already not getting enough. If we try to keep them together, the heart will likely fail completely and we could lose both. The father nodded once, sharply, as if he could accept loss if it behaved like math. The mother's eyes widened, and for a moment she looked almost relieved. 2 lives, tied to one heart, was a nightmare she understood. Then she caught the second half of what I hadn't said yet, and her relief dissolved into terror. I took a breath and felt the weight of the next sentence settle behind my teeth. If we separate urgently, I said, we can route the blood supply to the stronger twin. But the weaker twin, because of how the vessels are shared, would almost certainly die during the operation or shortly after. There isn't a surgical configuration where both survive. Silence doesn't always mean calm. Sometimes it's a body's way of preventing itself from exploding. The mother stared at the table edge like she was trying to focus on something that couldn't betray her. The father's throat bobbed once, and he looked at me with a kind of rage that wasn't directed rage at biology. Achi randomness at anyone who ever said medicine could do anything. The ethics consultant finally spoke, gentle but firm. Our role is to help you understand the options and what the law and ethics allow, she said. In situations like this, we focus on the best interest of each child, and also on the reality that doing nothing is also a decision. The mother's voice came out hoarse. You want us to choose which one lives. The chaplain shifted slightly, a quiet movement in the corner, like even the air felt heavy. I wanted to tell her no, wanted to spare her the shape of the guilt. But lying here would be its own kind of violence. The situation is forcing a choice, I said. Not you. No, but yes, there's a path that likely saves one and a path that likely loses both. The father's hands finally moved, gripping the chair arms until his knuckles blanched. What about a transplant? He demanded. People get heart transplants. Put them on a machine. Ecmo. Whatever it is you do. I nodded, because he deserved the respect of an answer, not dismissal. Ecmo is a form of life support that oxygenates blood outside the body, I said. It can buy time when a heart or lungs fail. But Ecmo requires certain anatomy and enough vascular access to run the circuit safely. With their shared circulation and size, it would be extremely high risk, and it doesn't solve the core problem. One heart serving 2 bodies. And a transplant? He pressed. In infants. Donor hearts are rare, I said, feeling the bluntness scrape my throat. Listing takes time, and they're critically unstable. Even if a heart were available, which we can't promise implanting it into conjoined anatomy isn't something we can do on an urgent timeline. I'm not saying it's impossible in theory. I'm saying it's not a rescue we can reach in the time they have. The mother's shoulders began to shake without sound. The nurse who'd come in with them placed a hand lightly on her back, not rubbing, not trying to fix it, just contact. Proof she wasn't alone in her body. The surgeon beside me cleared his throat. If you choose separation, he said, we will do everything to keep the weaker twin comfortable. If there's any chance any unexpected enemy that allows more sharing than we think, we will take it. But do not promise miracle. I can only promise you we won't treat either child like a problem to be solved. The ethics consultant spoke again, and I watched the parents' faces as they tried to hold on to her words like a railing. There's an ethical concept called the rule of double effect, she said, translating as she went. Sometimes, an action intended to achieve a good outcome saving one child has a foreseen but unintended harmful effect, the death of the other. The intention matters. But so does proportionality and the absence of less harmful alternatives. The father flinched at the word unintended, as if it were a loophole someone was trying to crawl through. It sounds like you're dressing it up, he said. Like if you call it something, it hurts less. It doesn't hurt less. I said quietly. "It just helps us make sure we're not doing something reckless or self-serving. It's a way to keep ourselves honest when the options are brutal." Then came the part no one teaches you to say out loud in medical school. "If you cannot decide," I said, "we can continue maximal support until the heart stops. But I need you to understand what that means. It means the decision will be made by physiology in the middle of a code, with compressions and medications and chaos. It won't be gentle, and it may end with both of them dying." The mother lifted her eyes to me, and in them I saw the same thing I've seen in hundreds of families: love turning into terror because love has nowhere to put itself. "If we choose separation," she whispered, "will the one who dies, will they suffer?" My chest tightened, and I forced my voice not to crack. "We will not let them suffer," I said. "Anesthesia will keep them asleep. If we reach a point where survival isn't possible, we will focus on comfort. We will treat that child as someone, not as an outcome." The father's gaze drifted toward the window, beyond the conference room, toward the Picu where machines kept making promises the body couldn't keep. When he spoke again, his voice was smaller. "They're not the weaker one and the stronger one," he said. "They have names." He said them, both names, and the room changed. The syllables made them real, in a way anatomy never could. I repeated the names back to him careful, like I was holding something fragile. "Okay," I said. "Then we do this with their names in our mouths, not numbers. We do it with respect. But we have to decide soon." Outside, the ventilator continued its steady rhythm, and somewhere down the hall a pump alarm chirped high, insistent like time itself was tapping its foot. Consent arrived on a trembling signature pad. The mother's hand guided by the father's fingertips, as if they could share the blame by sharing the motion. When they finished, the father didn't let go. He kept holding her hand like it was the only organ in the room still obeying him. I took the form back and felt the paper's weight as something indecent ink, pretending it could contain a death. In the scrub room, the water ran hot enough to sting. I scrubbed it until my nails were pale and my wrists ached, listening to the muffled rhythm of the hospital beyond the door, distant wheels. APA announcement, the steady pulse of alarms that never sleep. The resident tied my gown from behind, tugging twice to cinch it, and I thought of the twin-shared sternum, one knot of bone holding two lives together. The OR smelled like betadine and warmed circuitry. The perfusionist was already priming the cardiopulmonary bypass circuit clear, tubing looping like veins outside a body, filling with crystalloid and donor blood to make enough volume for 2 infants. Act target greater than 480, anesthesia said. As heparin went in, an anticoagulant that keeps blood from clotting in the machine that would briefly become their heart. The monitor displayed what we all pretended not to translate: lactate creeping up, pH drifting down, the smaller twins' blood pressure propped on medications that were running out of leverage. Their names were written on the whiteboard in block letters. Names change how your hands move. They don't make you. Gentler surgery can't be gentle, but they stop you from hiding behind anatomy. I leaned in as the drapes rose, leaving only the shared chest exposed. And for a moment my brain did that thing it does to survive. It turned skin into landmarks, vessels into problems to solve, and grief into an abstract future. "Time out," the circulating nurse said. She read the identifiers twice, then the procedure, then the plan. Everyone answered in turn: surgeon, anesthesia, nursing, perfusion, our voices stacking into a ritual that meant we were still human enough to check ourselves. No one said one will die. We didn't need to. It lived in the space between each response. The incision opened the world of small anatomy, tissue planes delicate as wet paper, tiny vessels that spasm when you look at them wrong. We worked under magnification, suction whispering, cautery hissing, the smell of singed protein briefly cutting through antiseptic. The heart sat where it shouldn't, broad, strained, working too hard, its surface glistening under the lights. I could see it struggling in real time, the ventricle squeezing fast, then failing to empty fully, like a fist that couldn't unclench, going on bypass, the perfusionist said. Cannulous plastic tubes went into the great vessels, and the circuit began to take over, pulling dark blood out, oxygenating it, returning it bright. A line on the monitor smoothed as the ventilator's work changed. The room exhaled a fraction. For a few minutes, science gave us the illusion of control. Then we reached the shared, outflow, the single conduit that made this whole existence possible and impossible at once. It wasn't a neat tube you could simply divide. It was a branching, fused architecture, nature improvising under constraints. Pediatric surgery, and I traded glances over our masks. I speaking the sentence we wouldn't say aloud. There is no way to cut this without deciding whose brain gets oxygen. Clamp here, I said, pointing with a hemostat to the segment that, if we were right, would preserve the stronger twins' perfusion. The resident's hands hovered, waiting. Anesthesia watched the cerebral oximetry near-infrared sensors stuck to tiny foreheads that estimate how much oxygen the brain is getting. They're imperfect, but they give you something to stare at when you're terrified. The first clamp clicked shut with a small metallic finality that felt too loud. On the monitor, the stronger twin's saturation held. The weaker twin's numbers dipped, then dipped again, as if the body were searching for a detour that didn't exist. Cerebral RSO2 SO to dropping on twin B, anesthesia said, voice level but urgent. Down 10, I felt mo. I wanted to pause, to undo, to bargain with physics. But the shared heart had been bargaining for months, and it was losing. The longer we hovered in indecision, the more we risked both brains, both kidneys, both lives. Increase flow, I said to perfusion, knowing it was a cruel request. Flow through which vessels? One pathway was being cut off by design. The perfusionist adjusted the pump. The circuit hummed a fraction higher. The weaker twin's pressure rose briefly, a flicker, then sagged again as the distribution followed the path of least resistance toward the twin we were saving. The scrub nurse placed the next instrument into my hand without asking. She'd been reading my movements for years. Subtext is a language in an OR, the way someone holds suction a little closer, the way anesthesia keeps a finger on the epinephrine syringe, the way no one cracks a joke. Even the beeps sounded different, tighter, as if the machines knew to speak softly. Pediatric surgery looked at the anatomy, then at me. If we commit, he said, we commit now. There's no going back once we divide. I pictured the parents behind glass earlier. Mouths forming prayers the same way my team formed protocols. Repetitive, desperate, designed to create order. I pictured the father insisting they had names, and the way the room had changed when he said them. I forced myself to think in those names. Not in Twin A and Twin B. One child had a better chance at a life with lungs that weren't drowning in a heart that wasn't splitting itself in two. The other was already slipping, even with every medication we had. Commit, I said. We divided the shared structure with a series of deliberate actions that felt like slow motion: scissors, clamp, tie, suture, reinforce. Blood welled in bright bursts that suction swallowed immediately. The bypass circuit compensated. The perfusionist's hands stayed steady. I watched the cerebral oximetry for the weaker twin fall into a range that no longer represented danger. But damage. RSO22 is 2,828, anesthesia said. A pause. Now 2,424. Anesthesia, keep them deep, I said, and hated that I had to say it, hated the implication that consciousness could still be part of this. No awareness. No pain. The anesthesiologist nodded once and adjusted the infusion propofol, fentanyl medications that make the world disappear. Comfort isn't rescue, but it's the last dignity medicine can offer. For a moment, the weaker twin's heart activity, what little was still their own on the monitor, became erratic, a jittering line that looked like panic. Ventricular fibrillation, the electrical system firing without coordination, a heart trembling instead of pumping. In adults, you shock. In a baby this small, with this anatomy, with the plan we'd already set in motion, shock felt like theater. V-fib, the nurse called out. I stared at the line and felt something inside me go quiet, not from indifference, but from necessity. Continue comfort, I said. No escalations that compromised the survivor. The words tasted like metal behind my mask. The rhythm degenerated into asystole flat. The monitor alarmed, shrill and indifferent, until anesthesia silenced it. The sudden quiet in the room was worse than the noise. We didn't stop moving. We couldn't. The living twins' body still needed us, still depended on every stitch to hold. We closed the reconstructed vessels, checked for bleeding, reinforced patches where tissue looked too fragile to trust. The stronger twin cerebral oximetry improved numbers climbing like a slow sunrise. Blood pressure stabilized on less support. It wasn't victory. It was possibility. When we finally came off bypass, the heart that remained still the same heart, but no longer demanded to serve, two began to find a more sustainable rhythm. Not normal, never normal, but steadier. The ventilator continued its hiss. The room still too cold, the lights still too bright. I looked at the clock and realized we had crossed into a different part of the night. The kind where families think in before and after. I peeled my gloves off and saw my hands tremble for the first time. Not during the cut, but now when there was finally space for what we'd done to catch up with me. Outside the OR doors, someone was already waiting to ask the only question that matters. The one I couldn't answer with clean certainty yet. Did we save a life, or did we only postpone the grief? The OR doors opened like a lung exhaling, and the first thing that hit me was the smell clinging to the team betadine. Cautery smoke, that faint metallic tongue that lives in the back of your throat after hours under bright lights. Doctor! Halpern walked out with his cap askew, hair damp at the temples, and he didn't look at the waiting room right away. He looked at the floor, as if the tile could tell him which words were least cruel. I was already in the Picu room we'd prepped, warming blankets stacked like promises that never fully keep their shape. The surviving twin came in intubated, chest rising to the ventilators, rhythm. A chest tube snaking out to a chamber that bubbled softly with each breath. The monitors were quieter, now less frantic, but every number still felt borrowed. Mean arterial pressure hovering in the low 40/40s on a thin epinephrine drip. Temperature climbing back toward normal. Urine output only beginning to appear in the diaper like proof the kidneys hadn't given up. The arterial blood gas improved by degrees pH inching upward. Lactate slowing its climb tiny winds that never look like miracles from the bedside. A respiratory therapist adjusted the ventilator settings and said, almost to herself, better compliance. Her gloved fingers tapped the tubing, listening for condensation, checking for kinks. The way you check a garden hose, you can't afford to stop running. I watched the child's skin color shift from gray wax to something closer to peach under the warming lights, and my own shoulders dropped a fraction. Relief in critical care is never a celebration. It's just a moment you stop bracing for impact. The empty space where the other twin should have been sat in the room like a third person. There was no second set of leads, no second oxygen probe, no second waveform trying to argue with physics. Someone had labeled the bed space anyway habit, system, the hospital's need to catalog what the universe had already erased. I peeled off a roll of unused ECG stickers and tossed it in the trash. The adhesive crackled loud in the quiet. Don't the how the parents waited in a family consult room with a box of tissues that kept refilling itself like a cruel joke. I didn't go in, not at first. That moment belongs to the surgeon, the one whose hands made the final cut. But the unit has its own gravity, and eventually the mother's sob roar. Involuntary broke through the walls, and the sound turned staff into statues for half a second. No one looked at each other. We all pretended to be busy because witnessing is its own form of pain. When Dr. Halpern came back, his voice was flatter than it had been earlier, like he'd sanded off every edge so it wouldn't cut them again. They passed during the operation, he said, and I could hear what he didn't say, because we chose this path. The father asked one question only, one, were they asleep? And when the surgeon answered yes, the father nodded like a man accepting a sentence from a judge. Not because he agreed, but because there was nothing left to appeal. A chaplain walked the parents to the bedside later. We turned the lights down, silenced non-essential alarms, and I dimmed the monitor screen so the numbers wouldn't compete with the child's face. The mother leaned over the surviving twin and didn't touch it first, hovering her fingers above the cheek as if contact might break something fragile. Then she pressed her lips to the forehead, one kiss, then another, and her tears slid into the tape holding the endotracheal tube in place. "We can't hold them. Can we?" she whispered. It wasn't anger. It was the kind of question people ask when they're trying to learn the rules of a world they never wanted to live in. "Not yet," I said softly and adjusted the lines to give her room. "But you can still be close. You can still talk. Families forget that a ventilator doesn't turn off hearing, doesn't erase the need for a voice that knows your name." The father stood on the other side of the bed, hands in his pockets like he was afraid of what they might do if he let them out. He stared at the chest tube chamber, at the slow rise and fall, at the steady pulse on the monitor, and then his eyes slid to the blank space at the foot of the bed where two bodies used to be one problem and one miracle at the same time. He didn't cry. He just kept swallowing, over and over, as if grief was something lodged in his throat that might eventually down. Back in the clinical rhythm, we chased the threats that still hovered. Post-op, bleeding meant checking the chest tube output every 15 minutes. Watching the fluid color change, watching the level creep. Hypertension meant titrating presses with a light touch, trying to support perfusion without asking the healing heart to sprint. We started broad-spectrum antibiotics because surgery plus critical illness is an invitation for infection. And the pharmacist confirmed weight-based dosing like the child's body hadn't already been forced into adult decisions. Neurology was paged for a baseline exam, though exam is generous for a sedated infant. We placed EEG leads tiny stickers that read brain activity because the earlier hypoxia and the intraoperative instability could leave scars no one can see at first. The fellow explained it to the parents in plain language. We were looking for seizures, for quiet electrical storms that sometimes follow big physiologic insults. The mother listened as if each word was a rung on a ladder she needed to climb out of the day. Near midnight, the yule into its strange crisis hush. The hallway lights stayed bright, but inside the room, the world narrowed to soft ventilator breaths and the occasional click of an IV pump. I changed the survivor's dressing, wiping dried blood from the skin with warm saline until the redness faded. And the simple act felt almost intimate, like apologizing with my hands for what the world had demanded. At the nurse's station, someone had placed a coffee cup side by side without thinking. One was untouched. I threw it away, and the cup hit the trash can with a hollow sound that made me flinch. Later, when I came back to chart, I saw Dr. Halpern standing alone at the window at the end of the hall. Shoulders rounded, looking out at a parking lot that didn't know what had happened inside these walls. Before shift change, I went back into the room. The surviving twins' numbers were steadier now, still fragile, still dependent on machines, but no longer slipping. The mother sat in the chair, one hand resting lightly on the child's ankle, and she was humming something under her breath, a lullaby with no melody I recognized. The father finally let his hands out of his pockets and rested them on the bed rail. Knuckles relaxed, as if he'd decided that even if he couldn't hold both children, he could at least hold on to the present. I watched them for a moment and understood the shape of the aftermath. One child alive, one child gone, and a family forced to love inside an absence that will never stop taking up space In this unit, we call it survival. In a home, later, they'll call it a quiet room that never got used. 2 weeks later, the smell of the OR still showed up in my dreams, betadine and cautery smoke, even though my hands had long since stopped trembling. I'd be driving home past the same billboards and insurance ads, and my mind would snap back to that single metallic click of a clamp closing, as if the sound lived permanently behind my ribs. In daylight, the decision looked the same as it did at 3:33 a.m., brutal, precise, and irreversible. 2 weeks later, the survivor stayed in the PICU for 9 days. Then step down, then the cardiac floor, where the alarms are fewer but the silence feels louder. The first time I saw them extubated, their cry came out ragged, half hoarse from the tube, but it was still a crier moving through a throat by choice. Their sternotomy scar sat fresh and pink, a line that would fade with time but never disappear. They had complications the way these stories always do, fluid shifts that made the lungs sound wet. A run of ectopy on telemetry that made the nurses pause mid-sentence. An EEG that kept us watching for seizures that never came. A resident asked me, quietly, whether I thought the neurologic outcome would be good. I told him the only honest answer: we wouldn't know for months. And certainty is a luxury medicine rarely earns. The parents learned the unit's language in the same way families always do, fast, under pressure. They started saying pressors instead of those meds, satting instead of breathing okay. And they stopped flinching every time a pump alarm chirped. The father still checked his phone constantly, not for updates from family, but for calls from the insurance case manager, authorizations, coverage, the paperwork scaffolding that tries to stand next to grief and look relevant. On day 5, the mother asked to see the other twin. She didn't ask in a dramatic way. It was almost administrative, like she was requesting a missing document. The morgue liaison met her at the elevator, and when she returned, she looked lighter and more shattered at the same time, like something in her had finally stopped fighting reality. She never described what she saw. She only said, "Thank you for keeping your promise," and as she meant, asleep, no pain, no spectacle. The scar, we talk about scars like they're evidence of healing, but in this line of work they're also evidence of what we had to do to get there. The surgeon's scar is invisible sleep that won't come, a jaw that clenches during benign disagreements, the sudden irritation at small complaints because you've seen what real pain looks like. Mine lives in the way. I now hesitate before saying we'll do everything because I've learned how much damage that sentence can hide. The ethics consult note went into the chart, neat and well phrased, full of words that try to make chaos legible. Proportionality, best interest, no less harmful alternative. It was correct. And it still felt inadequate, like describing a fire by listing the chemical properties of smoke. The truth was simpler and uglier. We accepted one death to prevent 2, and we did it with our eyes open. The father asked to meet me before discharge. He waited until the hallway was empty, until no one could witness him fall apart. And then he said, "I hate you for being right." He said it like a confession, not an accusation. I nodded, because anything else would have been a defense. And defenses are for courtrooms, not for a man who just learned what it costs to keep one child. He kept going, voice low. I replay it. What if we'd waited? What if a donor heart existed? What if God would have? His sentence broke in the middle, and he stared at his hands like they belonged to someone else. I didn't interrupt him with reassurance. I let the silence do its work, because some questions don't need answers, they need witnesses. When he finally looked up, he asked the one thing people ask when they're trying to map a new morality. Would you have chosen the same if it were your kids? My throat tightened. I told him the closest thing to truth I can offer without turning my job into a sermon. I would have wanted someone to tell me the reality in time to choose. And I would have wanted my child, both of them, treated like someone worth loving, not like a problem worth solving. Would I tell myself after discharge? The unit absorbed the case the way it absorbs everything. It moved on, because it has to. Another ambulance arrived. Another kid needed epinephrine. Another family needed a room with tissues that refill themselves like a curse. Still, when I walk past the trauma bay, I hear the earlier alarms in my head, and I remember how the monitor begged before it screamed. On the last day, I watched the mother buckle the surviving twin into a car seat with hands that now knew medical tape and diaper tabs equally well. She paused, then tucked a small knitted beside the baby one extra hat. The gesture was quiet, almost private, and it hit me harder than any wail in the hallway. Grief doesn't always shout. Sometimes it folds itself neatly and rides home in an empty space. I keep thinking about the hook people crave the sharp question. Who would you choose? It makes for a clean cliffhanger, but living inside it is filthy and slow. In the end, nobody chose like a villain chooses. The heart chose by failing, and we chose not to let it take both. The lesson isn't that medicine is powerful. It's that even at its best, medicine is a language for negotiating with limits. That's the scar I carry forward, a deeper respect for the moments when there is no victory, only meaning. Sometimes the most human thing we do isn't curing it, staying honest, staying present, and keeping our promises about dignity when the outcome can't be kind.